I'd like to speak to you about the nursing workload and ERAS. When we start ERAS, well, 2 years ago in our department, I had different feelings about the nurse. They told me that some stuff that are very good, like the multidisciplinary work. They feel that the patient is less stressed, less anxious. He's better informed. We have a better compliance with the patient. We have a better nausea and pain control. And the nurses see that we have less complication. But they have two questions. They thought that if the patient go out early, so we could have an increase of the readmission and an increase of the nursing workload. So I was interested to work about the increase of the nursing workload and ERAS. We know with the study of Gustafsson in 2011 that if you want an increase to the adhesion to ERAS, you have a better postoperative result. That means you have a decrease of the symptoms, a decrease of the morbidity, and a decrease of the readmission. With the ERAS implementation in our department, we have standardized all our management. We introduce care map for the major surgery, and the patient is the real actor of his management. So if you want an increase of the compliance, you need an enhanced recovery, you need a decreased complication, and a decrease in the length of stay. Is what we know with ERAS. But what about the workload? We introduced the clinical pathways. We have medical prescriptions and nurse prescriptions. We have also a tool, which is the PRN, so it's a predictive research nursing tool, which measures the volume of the nursing task needed for 24 hours. In this tool, we can measure the volume about the treatment, about the exams, about the time we need to the relation with the patient, and other things like that. For the study, the method is the following one. We have 267 patients in between 2010 and 2012. We have in these patients 50 patients which are before ERAS, they are retrospective. We have introduced only the patient with the elective colorectal surgery and the ERAS patients. You can see that the groups are very similar. The studies show us that the nursing workload increased at D1, and we have different explanations for that. The first one is we remove all the catheter for the patient, so it's a little bit more work for the nurses. We help the patient to mobilize if they hadn't mobilized at D0, so we need a nurse because the patient is not independent, and we have other probably explanation. In this graph, you can see the nursing workload before, during, and after the implementation. We saw that in 2010, the mean PRN was higher than in 2012, and in 2012, we have significant results. The decrease of the workload is a regression trend between 2010 and 2012. It's in relation with the compliance. That means if you want to have a decrease of the PRN score, we need to have a better compliance. So if your compliance is very high, we have less workload for the nurse. In 2011, here on this graph, it shows that the nursing workload decreased with the compliance. We have three groups of compliance, less than 50%, between 50 and 75%, and more than 75% for the compliance. When you have more than 75% of the compliance, we have a result that is significant comparative to the 50% compliance. In conclusion, if the nurses can anticipate the nursing care, if we can have a multidisciplinary teamwork, if you standardize your management of the patient, you decrease the stress for the patient so he's better and independent. You introduce some pathway and habits. The response to our question is that the nursing workload is decreased in colorectal surgery elective. And of course, we have happy nurses. Thank you for your attention.